Welcome, everyone. It's great to have you with us today. I'm Tim Murphy. I'm the General Manager of Blood Cancer Partnerships at the Leukaemia Foundation, and it's my pleasure to welcome you to this webinar today, where we talk about our partnership with Western New South Wales PHN and HealthShare to deal with the blood cancer challenges right across our country. I'm calling from Ghana country, and I offer my acknowledgement and respect to First Nations people right around the country who offer great guidance to us as we think about care and living well as we live on this great country together. And they guide us in our principle of working and a practice of working with regional and remote patients right across Australia. The meeting today is designed to take you through the ongoing work that the Leukaemia Foundation has been doing for over 50 years in caring for patients right across the country who have a need for supportive care and kindness during their blood cancer diagnosis and treatment. What we're going to take you through is how this new program will enhance that care. The program today is with Radwan Taluka from the Leukaemia Foundation. Then he'll take us through the new regional remote project. Our partnership with HealthShare will be led by Arun Mathai, who's going to take you through the digital support tool we're working in partnership with HealthShare to deliver. And then our colleague at Western New South Wales PHN, Katie Pryor, will talk about what it means on the ground. So there's a little bit of housekeeping. The presenters are in one part of the Zoom call and our participants are in another part. This is how the joy of Zoom. So if participants have a question, please put up your hand or use the chat function. I'm sure our presenters will be happy to take questions throughout the discussion. Otherwise, we can hold them to the end. So I'll hand over to Radwan to take you through the conversation today. Thanks, Radwan.
Thank you, Tim. And thanks everyone for joining. I will just bring up my presentation. Can everyone see the slides?
Yes. Do you want to make that full screen?
Yes.
Yeah. Awesome. Thanks, Radwan.
So thanks everyone. Today we'll talk about the new regional rural remote blood cancer control program. Just a bit of background. I'm a medical doctor with public health background. Before joining Leukaemia Foundation, I worked across Northern Territory, both in Alice Springs and Darwin, and mostly with First Nations community, which gave me a broader understanding of the regional health service challenges. I would like to begin with acknowledging the traditional owner of the land that we meet on today across Australia, here in traditional owners of the Kaurna people in Adelaide region, and I pay my respect to the past, present, and emerging. I will just briefly talk about, give you an overview of the blood cancer, what is the regional, rural, and remote program, and what are the program components, and what are our next steps. And at the end, we'll have the question and answer opportunities. So blood cancer is, as you're probably aware of, that it affects blood or bone marrow and or lymphatic system. And it is the third most common cancer in Australia. There are more than 120 different types of blood cancer, but most common are leukemia, lymphoma, and myeloma. And currently there are 150,000 people are affected with blood cancer, living with blood cancer. The pie graph that on the left bottom that you can see here is the incidence of blood cancer, and most common is the lymphoma, followed by leukemia. That's the inner circle, and the outer circle is the different subtypes of, for example, leukemia or lymphoma.
Radwan, sorry to interrupt you. I just want to check. I can't actually see that graph on the screen in full. I just want to check if that's the same for other people in the call?
The chart that I talked about, the left one, is the lymphoma is the most common cancer diagnosed in Australia, followed by leukemia. And it is the second highest cause of cancer-related death, blood cancer overall. And among those, usually, the predominant cause of death is the leukemia and followed by lymphoma. And the burden of blood cancer will grow. So both incidence and prevalence of blood cancer will be doubled by 2035. As you can see in this graph on the left, the incidence of blood cancer showing the growing trends of incidence of blood cancer and by different subtypes. And this growing burden will have significant human and economic impacts. There will be an estimated that in 2035, there will be more than 186,000 deaths from blood cancer. And this will cost almost 72 billion to our economy. But this impacts our regional and rural Australians very disproportionately. Only 28% of Australian population are from regional or rural areas, but they account for 41% of total blood cancer incidence. And there are high incidence in regional and rural areas as we move out of. As you can see in this orange, that usually in the major cities and in nationally as well, the incidence of blood cancer is 60 or 61 per 100,000 population. But as we move out and across regional areas, in outer regional areas, it is 72 per 100,000 population. This graph, this is a national graph which showing total blood cancer incidence blood cancer was diagnosed in 2022 by primary health network areas. And this is the number that we got for Western New South Wales PHN, that is the total incidence. But if we look at this incidence is 92 per 100,000 population, so which is way higher than the major cities and also the national averages. And what we also know that people living in regional areas are significantly face geographical and financial barriers to care than people living in metropolitan area. And because of low socioeconomic condition and the poor health service access also contribute to overall poor health outcomes. Some of the unique challenges with blood cancer detection. Blood cancers are not that common. It is spontaneous, and there are some of the symptoms overlap with common illness and other illnesses as well. Therefore, it is very challenging to readily diagnose in primary healthcare settings. The State of the Nation survey that was conducted with the patient living with blood cancer that shows around 38% of people reported delay in referral or inappropriate referral before being diagnosed with blood cancer, which means there is less recognition of the blood cancer signs and symptoms in the community and primary healthcare settings. And a recent survey that was commissioned by Leukaemia Foundation that also reported that 82% of people were not aware of any symptoms associated with blood cancer. And unlike some other cancers, there is no preventative health strategies to tackle blood cancer. What we know from evidence that if we could eliminate this metro-regional service inequities, then it saves lives. For example, we could save over 22 to 35, more than 7,000 deaths if we could address these service inequities. To address this survival gap, Leukaemia Foundation has took this project initiative to provide evidence supporting early timely diagnosis of blood cancer and to enhance post-acute treatment support for individuals diagnosed with blood cancer through primary healthcare services in selected regional areas. And this is a proof of concept model demonstrating innovative ways to enhance support to regional Australians. This is a 2-year program that has started this year. So last year, we had a co-design consultation with several health service partners, and that resulted in our proposed 4 interventions that I will present now. And it would be good to look at in the context of the traditional healthcare journey. So this is the traditional healthcare pathway where a patient, when feels unwell, see a GP, and from GP, if they thinks this is appropriate, then advise blood test, and from there, once there is required, referred to the specialist, and from there the definitive treatment happens. So as I mentioned earlier, what we know, there are delay in the care seeking. So our first intervention that we propose more eyes on the patient, what we would like to achieve through this component, we would like to make our allied health staff and the nurses aware of the blood cancer signs and symptoms so that they can direct patients to seek care from GP without delay. Second one is to enhance support to GP at the point of care through the implementation of a digital triage workflow within the GP software system, or making some resources available within the health pathways. And I will talk about the digital health triage workflow and the risk assessment tool in next few slides. And the final one is phone a friend and the blood cancer wellness programs to build a shared care model between the tertiary physician and the general practitioner to provide a more support when patient is returning to the community post-acute treatment when they are presenting with the common health problems, so that they can feel confident to support the patient in the community. So some of the evidence around the risk assessment tool related to blood cancer. So this is an example of non-Hodgkin's lymphoma. This study was conducted in UK with the primary healthcare data. And there are two tables. Tables on the left is, and it is showing the probability of diagnosing cancer through the symptoms or blood results. And on the tables on the left, that I would like to highlight this one. The first row is the symptoms, different symptoms, just single symptoms. And the blue one is showing the probability of blood cancer from those symptoms as a single symptom. But on the right in this column, there are other symptoms. So we can see most of the symptoms here that as a single symptom actually have a very low probability of diagnosing lymphoma. But when we combine them, say for example, with the lymphadenopathy, lymph node swelling, and the weight loss, there is a very high probability of blood cancer. That is more than 10%. And in terms of the cancer diagnosis, it is considered very significant. And on the right one, it is showing when we combine some of the symptoms with the blood results, there is also high probability of blood cancer diagnosis. And in this case is the lymphoma. So here is another example of the multiple myeloma, and it is again another example from UK. Here we can see the single symptoms itself, and even the combined, there is a very low probability of diagnosing multiple myeloma. That is on the left table. But when we combine these with the laboratory results, for example, with the leukemia and fracture, it gives more probability of diagnosing multiple myeloma. So some of the recent advancement with the research, this is a study from USA, which looked at applied machine learning approach for diagnosing myelodysplastic syndrome. And they included demographic results, vital signs, and laboratory measurements, different parameters. And they used previous 2 years medical record and run the algorithm, and then they looked at the probability after 1 year of diagnosis. And this one is showing there is very high sensitivity of specificity applying the machine learning model in diagnosing myelodysplastic syndrome. And the final one, cancer and the high platelet count. And there is growing evidence of relevance of high platelet count in the detection of the blood cancer early, and especially in terms of lung cancer, esophageal cancer, which are already part of a cancer council guidelines that you may be aware of. These are the pie graphs that are showing diagnosis of different cancers following detection of the high platelet or thrombocytosis in the primary healthcare data. And the inner ring is showing different cancers. I mean, it has been separated by male and female, and inner ring is showing the proportion of cancers who were detected, there was when the thrombocytosis was detected, and following that, how many were diagnosed with different cancers. But we can see here that they have identified different, there is a big proportion which was considered as the other, and they didn't report any association with blood cancer. So our Canadian colleagues who looked at the incidence of cancer among adults with thrombocytosis, and they reported about the blood cancer. And this study reported that with the thrombocytosis, there is very high risk of detecting any blood cancer from identification of the thrombocytosis. And we can see within 6 months, there is very high risk of developing any blood cancer from that. And it goes on 6 months to 5 years. And you can see that with 6 months, there is a very high risk of developing this one. So this evidence tells us that there is a probability and potential to apply risk-based approach to detect blood cancer, and especially the indolent type of blood cancers that we can do. And our blood cancer or digital triage workflow that we develop at this stage, this is a symptom-based approach that we are doing, but further refinement of the workflow will happen, that has been planned with incorporating other blood results in this workflow. So just as an example of the digital triage workflow, how it will work, this is one of the many workflows that has been built within the Better Consult. We have a health share team who will talk about the Better Consult, but just to give an overview with related to the blood cancer workflow, how this works. So, and there are 3 steps with this one, and the Better Consult is compatible with the best practice software system. And there is the pre-consult questionnaire. When patient fills out that pre-consult questionnaire, and that the tool will look at the relevant data in the medical record, and it will provide a summary and make a prompt to GP with advice based on the best available guideline practice. So this is just an example of the workflow that has been built within the Better Consult workflow related to. This is an example of the fatigue workflow. And to make it robust, the workflow and the questions are designed in a way that we do not capture just the general fatigue or weakness. So there is the workflow will qualify those things and then present to GP how, and then there will be decision making as well. And this is an example of the prompt that GP will receive. So overall, that regional program is this is actually following the Australian cancer plan, and it not only will be beneficial for the regional populations, but will be older population, First Nations community, and we'll engage with all those communities as we move along. And we believe if it is beneficial in this setting, this can be scaled up for other rare cancers, and also in the metro areas will be, people from metro areas will be beneficial as well. So we just started rolling out this digital triage workflow with the practices that are already on board with the Better Consult at this stage. And the training component that we talked about, that is a self-led online training component, which will be available from early next year. And our idea is, and in parallel, we'll discuss with our stakeholders about the design of the phone a friend and the blood culture wellness program, what is required in the local context, then the service needs. And our idea is to implement all the 4 components at least 4 months, at least 12 months of period. And at this stage, we are collaborating with the Western New South Wales PHN, and also discussion in progress with other PHNs to implement this program. We have been discussing with Royal Flying Doctor Service as well. And there is in principle support for this one. And because there is a compatibility issue with the Better Consult as well, we need the best practice software system. So some of the sites that hand up for these projects we could not implement, but we hope that there will be other possibilities to build on this one. So lastly, how we you can support. We would like to request all the practices who are using best practice and those who are not on board to participate in the program and through the implementation of the Better Consult. And we anticipate at this stage that minimal resource requirement from practices. The training is, as I mentioned, is the self-led online training, and Better Consult is compatible with best practice, no additional cost for the practices. But we would like to receive your feedback on this. And HealthShare team will assist with the onboarding of the Better Consult. And we would like to, we request your support to promote and share the program info, for example, when the training will be available, and also the digital triage flow with the healthcare professionals. And feel free to reach out at this stage. I'll put this in the chat box, my email address and the web page address. But, and I'm happy to take any questions through the chat. And also, this will be shared during our QA session. Please share your feedback on the program. This QR box will be available during the QA session as well. And that's the end of my presentation. If there is nothing, then I will hand over to Arun to present the Better Consult.
All right, Radwan, I just have a quick question, if that's
yes,
okay.
Please. Yeah.
So just going back to your previous slide, you said that HealthShare would help onboarding of Better Consult. Do you have an idea of how long that takes for a practice and for their time?
I would like to leave it with Arun because he will just present that.
Okay, sure.
Yeah, so that will answer your question. Thank you.
Thank you.
Thanks for the question, Katie. So the onboarding with Better Consult itself, it's quite minimal and doesn't take too much of the practice's time. We've got a few, so in total, we give about 2 to 4 weeks for onboarding. So depending on the availability of the doctor to do training, things like that, and installation, it takes around that time. That's the kind of the maximum period. We don't see many practices getting to the 2 to 3 week period. But the actual installation and training and things like that, the actual training component and installation only takes probably about, in total, probably about an hour, depending on how many practitioners are actually getting Better Consult installed or being activated or require training. The training itself is quite simple for the practitioner. They require, in some cases, depending on the comfortability of the practitioners with the technology or just with technology in general, it usually takes maybe a 5-10 minute conversation with them. But we have digital resources like training videos similar to the one that we go through here. We're going to go through today. We share that with the doctors as well. They can watch on their own time and then obviously start using the program. It is a very simple process to actually understand. So the training component isn't a massive time. Okay. Doesn't take up too much time.
Wonderful. Okay, thank you.
And so just a quick introduction for myself anyway. So my name is Arun Matha. I look after Better Consult here at HealthShare, just to onboard practices and take them through the program. So I'll be taking you through just how it works as a whole, for not only for this particular purpose, but for just in a general practice in as a whole. I'll take you through how the patient journey works, how the doctors actually use the information, and what we have within the actual the system itself. So I'll start off the video. Sorry, the audio doesn't come through, so I'll just do the narration of it as well. So Better Consult, it's a pre-consultation questionnaire that allows the doctor to actually understand the patient's reason for visit, for turning up to the practice, as well as it helps them understand the severity, exacerbating symptoms, so things that you would usually get within that's, you can't see my screen. That's that's an issue. Let me just share my screen. You see that? Brilliant. So before I start the video, the main idea with Better Consult is to help the doctor understand the patient's reason for visit, giving them a bit of a heads up, but it also allows the doctor to understand why the patient is presenting and, how to categorize that patient in relation to severity, what things that should prioritize in the care of the patient and that specific appointment. These days, appointments are 10, 15 minutes maximum as a standard appointment. So in those times, we've got to maximize the amount of efficiency that a doctor has as well. And this does play a part of that as well. So with Better Consult, the journey actually starts with the patient booking in to see the practitioner. Once the patient, that happens at 24 hours before. So when the patient receives the SMS, they receive it at home. They'll get the SMS itself, click on the link itself. So once they've completed the questionnaire itself, they go through the different questions about. So with the questionnaire itself, the information goes through, the question goes through the reason for visit. In this case, the patient presented for depressed mood. So we will ask questions specific to that reason for visit. So with the Better Consult, we'll also provide screeners in there as well. So the K10 and the -21 is available through the actual questionnaire flow. So once they've submitted the questionnaire, gone through all the reasons for visits and the screeners, then it's submitted to the system, and then it's translated into medical summary for the doctor to review. If the patient wants to discuss more than one reason for visit, we just set the expectations with that patient to let them know that the doctor may not be able to see more than one reason for visit in that short time frame, but they can still add more reasons for visits in that consultation as well. Once the submission has happened, it gets translated into medical summary, as I mentioned, and then made available to the doctor to review. So from there, the doctor will come in, open up their day, see that Better Consult is written next to the name of the patient in their appointment book, open up that patient's file. Better Consult will give them a notification saying, hey, there's some information available to you for this patient. They'll be able to open that up and have a look at the information as well. So once they're happy with the information and happy to copy it across, you just click on copy notes or copy section. You can see the different sections of the notes as well. So you can see the K10 screeners are available there, support resources there, the Leukaemia Foundation information will be there as well in this particular scenario. We'll also have screening for COVID-19 as well. Once the doctor has copied the information, they just go back into best practice, right click and paste. So once they've done that, they're able to edit the information as they need to. Once they've edited the information, they can have their discussion with the patient and can continue the notes underneath. And if they would like to as well, they can actually use Better Consult as a bit of a heads up tool. So when they're starting at the start of the day, they just need to click on consultations. It'll come up with a list of patients who have completed Better Consult for that day, and they're able to look at those notes individually to determine which patient needs to be seen first or which patient needs to be changed in relation to when they're being seen, how much time is associated, and things like that. A lot of practices utilize that feature of Better Consult to create that efficiency to make sure that patients aren't, or time is actually used up efficiently as well. Anytime at any stage, if a doctor would like to look at the notes, they can always search up Better Consult's little search functionality there, type in the name of the patient and be able to do that. So if multiple practitioners are looking after a particular patient, one doctor is sick and they've completed it out and another doctor is taking over, there is always a coverage there for the other doctor to receive that information. Any feedback, any summary, anything like that that you provide to us comes straight to our team, and our clinical panel will have a look at that and review it, and then action it, and then obviously provide you that feedback about when it's available to you, specifically around workflows. That's Better Consult. So there's not too much more that the doctor needs to do from there. They will continue their consultation after they've copied the information across or reviewed it, and then they go from there. Did you guys have any other questions? Any questions about how this works or anything like that? One thing I just wanted to make a note of is that Better Consult is customizable in the way that it works. So if there is an appointment type that you don't want the SMS to go to, or if there's a specific age range that that you want to cap it at, you can do that as well. So there is a lot of customization that we can do within the workflow. I won't go through every single point, but you'll get a dedicated account manager who will look after you in that regard. They'll make sure that everything is customized to the ability that you require, and then it'll be available to you as well to make sure that the patients who are receiving SMSs from Better Consult are the ones that you want to receive SMSs as well. So,
Aaron, can I just ask another question? Sorry to be. I'm just wondering, if a patient gets the SMS to complete the questionnaire, can they decline from completing that and still attend their appointment?
Absolutely. So Better Consult is an optional questionnaire. So it's just an SMS that comes through to your phone. So they can ignore the SMS if they'd like to. A lot of patients do complete the questionnaire, but the ones that don't will just ignore the SMS or let the reception let them know that they don't want to be a part of the system as well. And that's easily done. They can actually opt those patients out from the reception table, or they can just contact us directly and we can opt them out as well.
Sure. Thank you.
Arun, I just have a question too. Going back on that video, but you don't have to go back. Where were the alerts? It was in the patient record. That's where the alert comes up that they've had the Better Consults.
So there's a couple of different notifications. So there's one notification when the appointment book is presented to the doctor. So when they're looking at their list of patients,
of course.
so there's a little notation that says Better Consult in square brackets next to the name of the patient who's done it.
Okay.
Also, if the patient's file is opened, what will happen is the application will throw out a Windows notification to let the doctor know that there's some notes available as well there, and they're able to click on that notification to actually pop up the notes specifically.
Okay.
There is another way, but that's just a little red dot to let you know that there's some new notes in there that haven't been looked at. So that's that little red dot as well on the icon that's pinned to the taskbar.
Okay, thank you.
Sorry.
Thanks, Aaron. Amy or Susan, any questions from you to Radwan or the rest of the team here before we throw to Kate here? Katie, I might hand it to you then.
I might just jump in with one quick question. This
Thanks,
is
Fiona.
for HealthShare. I would just love for you to explain that there are no additional fees for utilizing Better Consult.
Yes, absolutely. So there are no any extra costs to Better Consult. So there's no fees for the SMSs or the use of the program. It's all free for a practice who uses best practice. So yeah, we don't charge at all for those services at all.
Okay, well, thank you all so much for your presentations. That's really fantastic. And I think it's great to acknowledge the health disparities that we do have in regional and remote areas, and empowering our GPs and practices to catch things earlier is always crucial, and we have a strong focus on that. So yeah, look, it looks like a wonderful tool, and using digital tools is such a great way to enhance the care that we offer to our communities. In acknowledging that, I think we'll have to obviously send this out to our practices and test who's interested amongst all the things that are going on with the reform agenda and My Medicare. But certainly the questionnaire looks fantastic. Aaron, I'm interested, is there any data kept outside of the practice software within that tool?
So the information for Better Consult is deleted after 72 hours after the completion is done. So what happens with the completion is that the patient will complete the Better Consult questionnaire, and then the information is kept for the doctor for 72 hours. So that identifiable information is deleted after the 72-hour period, and the de-identified information or the clinical data that they have is de-identified and then aggregated for statistical purposes. Nothing is stored outside of Australia. It's all Australian-based servers and things like that in relation to all of our data. So we keep it all secure and encrypted in that way as well.
Wonderful. So to Amy, Alison or Susan, who are online, who are practice managers from our region, if you've got any questions or comments, we'd be really keen to hear them. But otherwise, we really appreciate you all attending today and sharing this opportunity with us, and look forward to seeing how the results progress.
Really appreciated everyone's participation today. It is a first in Australia process we're doing for blood cancers, and from Radwan and Aaron, we've seen the range of different potential symptoms. So we're really keen to get all feedback from on the ground in the field of how this is actually playing out. So please let us know through the practices what your communities feel as they go through this. We're really keen to get the data on trying to find early diagnosis, because we know that leads to better health outcomes, but we want to see what it really means on the ground for your practices and the changes that work day by day in the way you operate. So really keen to understand all that. Katie, I don't think we have any more particular questions coming up from Amy, Alison or Susan.
No more questions in there at the moment.
Radwan's given his email address. Please contact him directly if things are triggered after the conversation for you to think through, and we're happy to answer those questions for you. I think we might use the 7-second rule then, and say thank you for the presenters today, and thank you for you as practices for joining us, and we look forward to hearing how you go in Western New South Wales over the next few months. Thank you very much, everyone.
Thanks, everyone.
Thank you all.
Thanks, guys.
Thanks, everyone.
Yeah.